Welcome guys to part 3, that is loop diuretics. Okay, loop diuretics are the diuretics which are going to be acting on the loop of Henle, as the name suggests. So if we are considering this to be the loop of Henle, this is the descending part, the thin part, and this is the ascending part, that's the thick part. Okay, and the drugs will be acting here on the thick part, not on the thin part, because thin part only deals with reabsorption of water, no ions. Okay, but the thick part, it's the exact opposite. There is no reabsorption of water, but there is reabsorption of many ions like sodium, potassium, calcium, magnesium, and chloride. Okay, now specifically where these drugs are going to be acting is going to be the NKCC2, that is the sodium potassium chloride cotransporter 2. Okay, so what happens is it's the cotransporter which allows the entry of one sodium ion and one potassium ion, and to balance the two positive charges it's going to take in two chloride ions. That's as simple as it gets. Now the mechanism of the cell will be something like this. So let's consider that this to be the cell of the thick ascending loop, this to be another cell, this is one cell, and then there is another cell. Okay, this is the interstitium, that's blood, and this is the lumen, which is containing the urine. Now NKCC2 takes in one potassium ion, one sodium ion, and two chloride ions. And there is one more thing, that's the sodium potassium ATPase, which is expelling the sodium ions and taking in the potassium ions. Okay, now here we are seeing excessive influx of potassium ions, so there's going to be a potassium ion buildup. So we're still looking at the normal condition. So due to this excessive buildup of potassium ions, there is a channel which allows the potassium to move along its concentration gradient, okay, from place of higher concentration to a place of lower concentration, and potassium gets back into the urine. Okay, so potassium had a higher concentration over here, and so potassium moved over here along the concentration gradient so that it would not interfere with the functioning of the cell components. But the problem is here we are also having other ions like calcium and magnesium. So to balance the positive charge that is coming along with potassium, okay, the potassium here is moving against concentration gradient, not the charge gradient, okay, not the electric potential. So here, to balance the charge that the potassium is bringing in, the calcium and magnesium are reabsorbed. Okay, they pass through the interstitial fluid and get reabsorbed back into our blood. So this is the mechanism that we are going to be looking. Okay, so this is how the calcium and magnesium are reabsorbed. They're reabsorbed because of the potential gradient. Okay, so this is the mechanism of action. What happens? This is the mechanism of action of the normal loop of Henle. So in case of administration of loop diuretics, this thing is going to be blocked. Okay, we're blocking the NKCC2, and because of block of the sodium potassium chloride cotransporter, the sodium, potassium, and chloride are not being reabsorbed. Okay, so they are going to be present in the urine. So because of this blocking of the NKCC, there is going to be an increased excretion of potassium ions, sodium ions, and chloride ions, as they are not being reabsorbed. Okay, and since this potassium is not being reabsorbed, there is not going to be any reabsorption of magnesium ions or calcium ions, and hence a lot of ions are just going to pass out through the urine, and to compensate for this, there is going to be an increased urinary loss of ions and water. Okay, because of this, because of the high amount of loss of ions and high amount of loss of volume, these are called high ceiling diuretics. Okay, high ceiling diuretics, which means they are having a very large action on a large amount of volume and a large number of ions. So this is one of the characteristic features of loop diuretics, that they have very extravagant action. Okay, now mechanism of action is over. We'll come to the prototype drugs. Yeah, the prototype drug is furosemide. Now the drugs can be classified into two groups, that is sulfonamide groups and the other group, that is phenoxyacetic acid groups. Okay, now phenoxyacetic acid group, for example, we have ethacrenic acid. Yes, and the sulfonamide group has furosemide, torresemide and bumetanide. So also we have the mide, furosemide, mide, which shows the relation to the sulfonamide groups. And as we already saw in the drugs which are acting on the PCT, those were also the carbonic anhydrase enzyme inhibitors. In part 2, they were also sulfonamide group. They are also, the loop diuretics are also sulfonamide groups. So these are the drugs: furosemide, torresemide, bumetanide and ethacrenic acid. Okay, these are the drugs. Now all of them are similar in action, though they are belonging to the different group, and the characteristic feature is they have high efficacy. Okay, high efficacy and low duration. The duration ranges for approximately 4 hours only. So if you're going to use them for a long-term treatment, you're going to have to increase the number of times the dose is given. So the patient compliance will decrease, and in case of treatment of chronic states like hypertension, you're going to have to use things like thiazide diuretics. Loop diuretics, you can only use them in case of emergency situations where you need a rapid decrease in the volume, the interstitial volume. For example, like in case of hypertensive crisis or sudden increase in intracranial pressure. Okay, now after this, the effect on the body of loop diuretics, there is going to be the effects. Okay, the effects, there is going to be increase in volume. Volume is going to decrease in a rapid manner. There is going to be increased secretion of NaCl. Now in the normal condition, 20 to 30% of NaCl is reabsorbed in the loop of Henle. So you're going to have that much amount of loss of NaCl. Now because of rapid decrease of ions and volume, there is going to be a decrease in BP very fast, which is a good thing. Now you can use them in case of edema states. Okay, edematous states. For example, you can use them in case of pedal edema. You can use them in case of ascites also. So in case of edematous states, wherever you're having accumulation of fluid, these can also be used to decrease that. And the effect, the negative effect, one of them would be you're going to have decreased in calcium levels in your body, so hypocalcemia, which can lead to severe muscular complications. Then you're going to have decreased in magnesium content, okay, which can alter the pH. Decrease in potassium ions is going to lead to hypokalemic alkalosis. Okay, now this can be treated by two methods. One would be give potassium supplements orally, or you could use potassium sparing diuretics, which I will cover up in the upcoming lessons. Potassium sparing diuretics to prevent the loss of potassium or to minimize the loss of potassium along with loop diuretics. So it's almost a fixed drug combination to counteract the side effects of each other. Okay, the potassium sparing diuretics don't have a very good efficacy, but loop diuretics, though having a very good efficacy, lead to high loss of potassium. So those two drugs balance them out. Okay, Now, one of the thing is you're not supposed to use NSAIDs when you're using these things, because NSAIDs inhibit prostaglandin synthesis. Yes. Now, prostaglandins are responsible for diuresis, that is, they maintain the blood pressure in the glomerulus by constricting the arteries, and increasing BP leads to increase in diuresis. That's what we know. Now, when NSAIDs blocks the prostaglandins, the BP reduces and hence the diuresis decreases significantly. Okay, so when you're using the diuretics with NSAIDs, there might be some amount of problem as to loss in efficacy. So it's not actually advised because of the loss of efficacy, but it depends on the necessity of the patient and various other factors which should be left to the physician's judgment. Okay, now we'll come to the clinical uses on where all the loop diuretics can be used. The uses, as I earlier stated, they can be used in edematous states. Okay, like you can use them in ascites, you can use them in pulmonary edema, and they are used in decreasing BP in case of hypertensive crisis, and when decrease in BP is required to decrease the preload or afterload. So in case of congestive cardiac failure. Okay, so serious uses, and we have a pulmonary use also. And in case, this might sound a little weird, but in case of hyperkalemia, it is a very good drug to use in case of hyperkalemia. So we have hypertensive crisis, congestive cardiac failure, hyperkalemia, edematous states. Okay, now we'll come to the final part of this video, that is the adverse effects. Okay, adverse effects, as I already said, you're going to have loss of ions. So you're going to have hypocalcemia, hypokalemia, hyponatremia. These are the things which you can commonly expect because of the loss of ions. But the other things are hyperlipidemia. Okay, there is going to be increased amount of blood lipid levels, hyperglycemia, and because of the loss of potassium ions, they are known to cause ototoxicity. Okay, ototoxicity, because you know that the endolymph and perilymph are really ion sensitive, so ototoxicity can also be caused. Then they are known to cause serious complications because of the loss of ions. Now you know the heart muscles have to contract repeatedly, and they do so throughout your life, and for that contraction you're going to need some ions. You're going to need potassium and sodium for the maintenance of the resting membrane potential. You're going to need calcium for the actual contraction. So they're known to cause serious complications as well. And as I already said, hypokalemic alkalosis. Okay, hypokalemic alkalosis because of loss of the potassium ions. And last but not least, as I already discussed in part 2, sulfonamide allergy. Okay, sulfonamide allergy, which results from allergy to any of the sulfonamide drugs, let they be antibiotics, let they be hyperglycemia treatment, okay, or let them be diuretics in case of carbonic anhydrase inhibitors or loop diuretics. Okay, there might be cross allergy due to one drug, and that drug, allergy towards that drug, might lead to cross allergy amongst all the other classes of drugs. Okay, so allergies, so hypokalemia, hypocalcemia, hyponatremia, hyperlipidemia, hyperglycemia, hypokalemic alkalosis. Okay, and due to the problem with the calcium ions, you're going to get serious complications. Sodium and potassium also leading to serious complications, leading to ototoxicity as well, and sulfonamide allergy. So this completes loop diuretics, and I'll see you in the next video with a short topic called parathyroid hormones and how it affects our renal system. And then in the next video I'll be covering thiazide diuretics, and we'll move on as well. So thank you for watching, and If you want any specific topic to be covered in the upcoming videos, just leave them in the comment section and I'll try to get to them as fast as possible. Thank you for watching again.